Good morning, good afternoon, and good evening. I'm June Halper, and the CEO of the IOMSN, and very, very grateful to Actrims Ectrims for inviting us to this very unique and exciting meeting. 2020 is the International Year of the Nurse and Midwife, and today's program, as well as another one tomorrow, is a part of our celebration of MS nursing. As designated as the International Year of the MS Nurse Midwife, the IOMSN has conducted a number of programs, but this is the highlight. We were founded in 1997 and embody the best of nursing care in all those affected by MS in many settings and many circumstances. The content of this program, as well as the subsequent program, represents key activities in comprehensive nursing care presented by MS thought leaders. Founded in 1997 in Calgary, it's only fitting that I turn the microphone over to my dear friend, Colleen Harris from Calgary.
It gives me great pleasure today to meet you all this morning for me. And it gives me great pleasure to be part of this. And I'm very honored to introduce our first speaker, Megan Weigel, from First Coast Integrative Medicine. She's a nurse practitioner, and Megan has taught the world of MS nursing integrative medicine, and she is our expert, the person we go to when we are trying to deal with the whole person, the mind, body, the spirit, and she is going to give you a wonderful presentation on this very important area for all MS nurses. So take it away, Megan.
Hi, everyone. Thank you for joining this program during virtual Actrims. My name is Megan Weigel. I'm a doctor of nursing practice and an MS certified nurse in Jacksonville, Florida. I have a practice called First Coast Integrative Medicine, where I take care of people with neurological disorders and specialize in the care of people living with MS. Today, I'm going to talk to you about integrative medicine in MS, evidence for a paradigm shift to improve care. I'll present the spectrum of medical paradigms that includes integrative medicine, discuss risks, benefits, and challenges of practicing from an integrative medicine paradigm, and describe evidence for integrative medicine in the following areas: mindfulness and meditation, nutrition and supplements, and energy and manual medicine. I'll provide examples of using integrative medicine in a busy clinic visit that you can take home, and I'll present a breathing technique that you can also teach to patients. Integrative medicine has broad definitions. Two of my favorite are that it's a healing-oriented medicine that takes account of the whole person. It emphasizes the therapeutic relationship between practitioner and patient, is informed by evidence, and makes use of all appropriate therapies. And I think one of the tenets of integrative medicine is time. So consults, follow-up visits are a lot longer because of the number of things that are being addressed. It focuses on the least invasive, least toxic, and least costly methods to help facilitate health by integrating allopathic and complementary therapies. And these therapies are recommended based on an assessment of the physical, emotional, psychological, and spiritual aspects of the individual. In integrative medicine, we maintain that healing is always possible, even when a cure is not. And I think that's also an important tenet because it provides the person just such a great deal of hope, even if ultimately there's not an endpoint to the disease spectrum that they can see. I love this slide. I think it's a great pictorial of the spectrum of medicine these days that's available. We have conventional medicine, which is the medicine that most of us grew up studying. It's disease-focused. It treats symptoms using drugs, radiation, or surgery, and serves as a knowledge base for Western medicine. And then if we move just a little bit to the left of that, we have alternative medicine. Alternative medicine is used in place of conventional medicine. And then we have complementary medicine, which uses both alternative and conventional medicines to diagnose and treat symptoms. It's kind of a hybrid. Integrative medicine brings the evidence-based spectrum back into the medical paradigm. So it combines conventional and alternative medicine in a way that's a little bit more coordinated. So you'll have a conventional medical practitioner like me adding in complementary and alternative medicine to a conventional medical plan. And emphasis really remains on data-driven solutions, so it's still evidence-based medicine. And then at the far end of the spectrum, we have functional medicine, which sometimes questions the foundation of conventional medicine, treats the patient, not the disease, and is scientifically based in systems biology. So there's a strong focus on prevention rather than treatment, and you might be familiar with the term finding the root cause of the disease. That's a big buzzword in functional medicine. These are a list of the top 10 most common used types of complementary and alternative medicine therapies among adults in 2012. This is a survey that was done in the United States, so this is only representative of the US. You can see that many of these things are safe, but many of them require a level of care and assessment before recommending to patients, specifically supplements and even vitamins and minerals, as well as special diets and homeopathy. In general, in the United States, 33% of adults use CAM. More than half of respondents in this survey had used CAM 3 months prior to the surgery, and $30 billion of out-of-pocket monies were spent on CAM in the United States in 2012. In MS, CAM is used by 30 to 80% of people living with MS. Those folks are more likely to be female, have higher levels of education, and report poorer health. 90% of them are also using conventional medicine, but they may not be disclosing the type of complementary and alternative medicine that they're using to their conventional medical providers. Given that, I'll just go back here, natural products are the most common type of CAM used. It's super important for us to assess whether or not a patient is taking supplements and vitamins that might either theoretically worsen the course of their disease or interact with medications, including disease-modifying therapies. And that's one of the challenges of practicing integrative medicine in MS. There's a lack of evidence specifically for supplements. Many of the supplements that might be beneficial for mood or pain or energy in people living with multiple sclerosis are theoretically to be used with caution or contraindicated because they stimulate the immune system. If you take one thing away from this, know that as you do, that in multiple sclerosis, the immune system works wrong. And so when you provide or recommend a supplement that stimulates an immune system that's working wrong, you don't necessarily change the way it works. You could potentially worsen the disease. And that's why we're stuck with using many supplements in MS. Excuse me, many providers think it's a gray area, or that it's voodoo medicine or woo-woo medicine, as I like to say. If you practice functional medicine, you can really get bogged down in the details of toxins and genetic polymorphisms that may be present but not relevant or activated. And people can walk into my office with boxes of supplements that we have to go through. There are also perceived side effects and drug interactions of supplements and botanicals, specifically with warfarin or Coumadin. You know, the minute someone says they're on warfarin, we stop recommending many things that might be beneficial and safe. Also, many supplements have CYP interactions that people aren't familiar with. We want to be careful about the quality of intervention. So if someone wants to do something, is the referral source experienced, licensed, reliable, and safe? And same thing with resources for supplements and botanicals. And then, of course, people living with MS already have an issue with polypharmacy and likely with nutritional deficiencies. So it's a big soup to jump into. An integrative medicine treatment plan in MS includes a comprehensive medical history that, in addition to what we're usually used to asking about, focuses on spirituality, self-care, review of medication exposure over time, dating back to childhood, toxin exposure and supplement and botanical use, and also a review of significant emotional and physical events, sometimes prior to birth. So, when the mom was pregnant with the child. A good physical examination, and then development of a plan that's based on most benefit, least harm, least cost, and belief system of the patient. This may include medication adjustment, or it may include a supplement in place of a medication. It may include a laboratory evaluation that's conventional, or perhaps one that goes deeper and specifically is a bit more functionally based. And it may include referrals to appropriate providers. And these could be conventional medical providers that we've recognized as important, specifically rehab professionals or other medical specialists, but also providers that practice mind-body therapies, spiritual therapies, and manual therapies. And another big component of integrative medicine is being collaborative and communicative with other healthcare providers. So here's the toolbox for comprehensive MS care, and you can see that an integrative provider may fit in. Integrative medicine for MS means conventional treatments plus complementary and alternative treatments for which there is evidence. And it's careful examination of that evidence applied in an integrative setting to provide best care for a person living with MS. It is not piling supplements onto medications when there's no evidence for benefit. It's not recommending a fad diet with elimination of healthy food groups, and it's not throwing caution to the wind because of a YouTube video or a blog post. And, in MS, there's a drive from people living with MS to really hook on to anything that seems positive. And so they come to us with those examples, and they want our support. It's very, very important that we provide them with safe explanations for why we may not want them to follow those interventions. I'm going to talk briefly about comorbidities in MS, the most common ones being depression, anxiety, hypertension, hypercholesterolemia, and lung disease, and the most common autoimmunities being thyroid disease and psoriasis. The reason that I'm talking about these in this talk is because they're important to MS. They can worsen the course of MS. We know that a vascular comorbidity occurring at any time in the disease course results in a progression of EDSS of 6 by approximately 6 years sooner. There's also much more data for the use of integrative medicine in common comorbidities than there is in MS, particularly for cardiometabolic comorbidities, also for anxiety, depression, and pain. These comorbidities provide us with an additional opportunity for education for people living with MS, particularly for preventive education, for ways to help them improve their lifestyle and improve the states of their health and wellness, which ultimately improves the quality of life living with MS. Also, a recent report suggests that shorter telomere length, which addresses biological versus chronological age, is associated with higher disability and lower brain volume. And that shorter telomere length is also associated with cardiometabolic comorbidities. So let's move on to nourishment. I love this quote. Sir William Osler said hundreds of years ago, "It is much more important to know what sort of patient has a disease than what sort of disease a patient has." So why are we talking about mind-body medicine in MS? Well, depression and anxiety are common in MS. They're much more common than we previously thought. And we've also identified in the past few years an effort to address these because maybe we weren't addressing them well enough. Stress actually does increase neurochemicals that perpetuate the inflammatory response and that are involved in the immune response. And those studies regarding significant stressors in MS are conflicting. We do know that significant stressors are associated with an increase in MRI activity, and stress is likely to be associated with relapse. And that's major stressors like death of a loved one, significant divorce, and trauma. You can see on this curve here that it's very easy to go from that peak performance of healthy and focused to sick and fatigued. And I think that's something that many of us have probably experienced during the COVID-19 pandemic, right? Like you figured out something that you're going to get into and start doing, and and you get really focused, and maybe you're not sleeping as much, and then suddenly you're sick and tired, and you think, how did that happen? So this explains why. This cartoon shows mindfulness on the right and a mind that's full on the left. And our goal is to be like the woman on the right, which basically means we are 100% present in what we're doing at any given time. Jon Kabat-Zinn, who is the founder of mindfulness-based stress reduction at Harvard, says mindfulness practice means that we commit fully in each moment to being present. There's been a small study in MS that showed improvements in character and self-maturity, as well as anxiety, after an 8-week mindfulness-oriented meditation training program. Mindfulness slows down blood pressure and pulse, it slows down breathing, it decreases stress hormones, facilitates digestion, and has benefits for many health conditions. It also improves coping and resilience. And as noted before, meditation and mindfulness research in MS suggests that it's helpful for pain and anxiety. So you're shifting that sympathetic nervous tone to parasympathetic nervous tone. Another way that you can do this is through yoga. Yoga is a safe form of CAM if the teacher is experienced and knows about people living with MS. People living with MS need exercise, and yoga provides strengthening, stretching, and breathing exercises that are empowering both on and off the mat. It also provides a sense of community for people. Possible benefits that have been studied show improvement in fatigue, balance, spasticity, body awareness, self-esteem, anxiety, sleep, bowel and bladder issues, and again, in that sense of community. I have a nonprofit. We offer free yoga classes to people living with MS. We've gotten that program up and running virtually during the COVID-19 pandemic, and we still see that sense of community happening even on the Zoom platform. It's really quite incredible and beneficial. Let's move on to nourishment for the body. So we're talking about food and supplements now. To find health should be the object of the doctor. Anyone can find disease, said Dr. T. Still. Nutrition in MS is important because poor nutrition is associated with comorbidities, cardiometabolic risk, obesity and pain, bladder and bowel dysfunction, depression, fatigue, inflammation. And then we get to bring in this whole aspect of the microbiome, which we're seeing more and more studies about in the medical literature these days. I'm going to briefly present these diets. These are the ones you probably hear the most about from your MS patients. The first is the WALS protocol, which in studies show improvement in mood, fatigue, and cognition. The more closely it was followed, in addition to exercise and stress management. And also, again, in another study in fatigue. The paleo diet, which is similar to the WALS protocol, is not well studied in MS, but there has been short-term weight loss, reductions in blood pressure, glucose, and cholesterol measures. The Mediterranean diet has been studied in MS. A high intake of monounsaturated fatty acids was associated with increased cortical thickness. The Mediterranean diet has been associated with improved fatigue and feeling better and healthier. It has been studied for over 20 years in general. It doesn't restrict major food groups and has protective effects for cardiovascular disease, cancer, and cognitive health. And then the ketogenic diet is also really big these days. And let's think of it as the baby sister of the ketogenic diet that many of us know for treating epilepsy. This is not the same animal. A modified ketogenic diet looks more like a paleo diet. It has been associated with improved fatigue, depression, and insulin sensitivity in people living with MS. But again, most of this evidence comes from other disease states. It's very hard to assess diet. These studies in MS specifically are quite small. But I also wanted to present all of the evidence so that you know there's not just one way. These are my rules to live by that I talk to patients about. Reduce processed foods, eliminate sugar-sweetened beverages, eat a colorful plant-based diet, and use meat as a condiment. Buy according to the Clean 15 and Dirty Dozen. In the United States, these are lists that are put out yearly by the Environmental Working Group that basically tell you what vegetables and fruits you really have to buy organically. Make thoughtful seafood and animal protein choices. Eat your omega-3s, your nutrients, and your prebiotics so you don't have to take more pills. Prebiotics are foods with special types of fiber that feed the bacteria in your gut, and probiotics that you can eat come from fermented foods. Processed meats are grade 1 carcinogens according to the World Health Organization. These are salted, cured, fermented, and smoked foods, particularly beef and pork, to a lesser degree turkey and chicken. So choose those wisely and not often. And basically, eat food, not too much, mostly plants. Supplements in general, you know, big rules, huge buzzword in MS, and there are lots of claims made about brain health, fatigue, you know, anxiety, anti-aging. People very easily buy into these claims, and they don't have well done studies to support them. These supplements can have interactions with medications. As I mentioned before, they can theoretically worsen MS when someone might take them because they think that they're helping themselves. However, there is evidence, much more evidence than in, say, the treatment of MS symptoms. There's no evidence for the treatment of for modification of the disease coming from supplements. But for other conditions like pain and depression, DHEA, EPA, or your omega-3s, B vitamin and vitamin D supplementation may be beneficial. And in general, those are safe supplements for most people. If they're not on high doses of anticoagulants, antiplatelet agents, and have normal kidney and liver function. Encourage your patients to talk to you before they start anything new. And if you don't know the answer, find someone who does. The risk of developing MS is lower in people with higher levels of vitamin D, so we want to be assessing our vitamin D 25-OH levels in people living with MS. There's an association between higher levels and decreased risk for relapse and less disability. In general, we want to see a level around 50. Higher levels than 50 can be associated with adverse outcomes. I'll move to probiotics. Research in MS suggests that bugs are different in MS in the gut than in healthy controls. There was a probiotic study that showed that taking a probiotic decreased the dysbiotic strains in MS and actually induced a peripheral anti-inflammatory response, including a genetic response. There have been studies suggesting similar things for a probiotic called VSL number 3, which is now Visbiome. Dangers are that if someone is significantly immunocompromised, has certain medical histories, or has a central line, then septicemia or fungosemia could occur. So I'd like to talk about pre and probiotic foods that a person can take without being worried about any potential for harm, as you can see outlined there. Biotin is also a buzzword in MS. Studies show that it may be helpful in non-active progressive patients and also people who have visual loss from optic neuritis, but a more recent study showed an increase in annualized relapse rate and enhancing lesions. Biotin can interfere with certain lab tests. So again, I talk to people about eating foods that are rich in biotin, such as those listed on the slide. Lipoic acid, alpha lipoic acid, is an antioxidant. It's present in foods, but difficult to obtain in large amounts. There's been a small trial in secondary progressive MS looking at 1,200 milligrams of lipoic acid daily that showed lower annualized relapse rate of whole brain atrophy at 96 weeks. Let's move on to nourishment for the soul. For this is the great error of our day in the treatment of the human body, that physicians separate the soul from the body. And Plato said that. I can't even calculate how many thousands of years ago that was. Spirituality is a sense of connectedness with what is considered an absolute, immanent, or transcendent power, as well as the conviction, meaning, value, direction, and purpose that that power has and that a person has in their life. That this is not religion. And JCO actually requires a spiritual assessment of hospitalized patients in the United States. In 2009, prayer was the most widely used alternative therapy in the US, not supplements. talking about resilience, hope, and self-efficacy can help address spirituality in your patients. You can ask them questions like what really matters to them, what relationships matter the most to them, or you can use a spiritual assessment tool. George Washington has a great tool called the FICA evaluation that can be found online, George Washington University. So pearls for practice. In a busy clinic, you can still recommend a plant-based diet without getting caught up in the details of the name of the diet. You can give people information about the Clean 15 and Dirty Dozen, or about the best ways to buy safe foods in your country. You can quickly discuss natural antidepressants and energy boosters, like following a plant-based diet and limiting processed food, sugar, and alcohol, getting outside, exercising, and doing a sleep assessment. You can still give a resource for a meditation app or teach a breathing exercise. You can warn about the dangers of supplements and claims that are made on the internet. And if you can't be a resource yourself, then find some good ones in your community as referral sources. So right now, I'd like to teach you the 4-7-8 breath. We're running low on time, but this takes 19 seconds. You're going to put your feet flat on the ground, close your mouth. I'm just going to talk you through this first. Close your mouth and you inhale through your nose to a 4-second count, hold it for 7 seconds, and then open your mouth and completely exhale for 8 seconds. So let's completely empty your breath, exhale, close your mouth, and inhale through your nose. 2, 3, 4, hold your breath. 3, 4, 5, 6, 7, open your mouth and exhale, sigh. 3, 4, 5, 6, 7, 8. 19 seconds. Do that 3 times. I guarantee you a sense of peace and an uplift in your mood after practicing. So I'm trying to see the questions. And I'm just, there's I don't know if support can hear me, but the presenter chat box is in the way of me seeing the questions. Okay, I just moved it. Okay, I'm going to start with the questions that are coming through. And someone just give me a heads up when my time is up for this. So hello from Colombia. Hello, Lorena. Thanks for listening in. The first question is, which vitamins and herbs are known to worsen MS, and is there evidence for this? Hey, buddy, I'm talking. Thanks. So there is no really good scientific evidence to tell us that the vitamins and herbs that might worsen MS do. We rely on, there's actually quite a bit of scientific research about how particularly botanicals work because they've been used for thousands of years. So many Ayurvedic herbs, for example, ashwagandha is the one that comes to mind, which actually has been studied in MS for things like fatigue. But theoretically, these drugs are immune modulatory. So they actually can have an effect on the immune system. And in fact, they could even potentially have an effect on how disease modifying therapies work, including making them potentially less effective or more effective. So when you read about an herb or a botanical or a supplement, and it says that the purpose of that is to enhance the effect of the immune system, you don't want to enhance the effect of an immune system that already isn't working right, because you will make it theoretically work more wrong. So I hope that makes sense. I'm happy to be a resource for anyone. There are also some great online databases for herbs. Yes.
I'm supposed to introduce Jennifer now.
Okay, so I'm just going to hold these questions.
Yes, you're going to hold them to the end, okay?
That sounds great. It was just dead.
Okay. Thank you. Sorry, guys, a little technological switch here. Our next speaker, looking at the comprehensive nursing care in MS, is Jennifer Boyd. She's a colleague from for the Hospital for Sick Children in Toronto, Canada. But for many years, Jen led the way. For many years, there were no pediatric clinics. And she sort of spearheaded her model, and she's been teaching ever since. So, Jen, I want to introduce you, and your topic is Pediatric MS, Caring for the Young Patient. Jennifer.
First of all, I am very honored to be invited to speak at the joint Actrims Ectrims virtual meeting, and in particular to participate in the nursing session during the International Year of the Nurse. And I'm pleased to speak to you today on pediatric MS, caring for the young patient. So many people don't realize that children do get MS, but about 3 to 5% will have pediatric onset disease. And majority are adolescents, with less than 1% diagnosed before 10 years of age. But you have to keep in mind that really young children have a difficult time reporting things like visual symptoms and sensory symptoms, so they may actually not report these symptoms, and then that causes delay in diagnosis even to adolescence or adulthood. So it actually may be more common than we think because it may be underreported. And vast majority of patients have relapsing remitting MS. Virtually all primary progressive MS is extremely rare, and secondary progressive MS is usually not happening until they're in their adult world. So what are the risk factors for developing pediatric MS? There have been a number of studies looking at environmental factors. Dr. Banwell and her colleagues with Dr. Alotabi looked at exposure to Epstein-Barr virus. They found that 83% of children with pediatric onset MS had exposure to Epstein-Barr virus versus age-matched controls, healthy controls, which was only 42%. Similarly, Mikhailov and colleagues in France looked at exposure to secondhand smoke. They found that 68% of their patients had developed, had a prolonged exposure to secondhand smoke and then developed MS. The more they were exposed to secondhand smoke, the greater the risk. Another factor they've looked at is vitamin D insufficiency. Heather Hanwell did a study looking at children who had clinically isolated syndrome, and she looked at their vitamin D levels and the risk of going on to develop MS. And 28% of those who were insufficient with their vitamin D levels developed MS, while only 7% of those with normal levels of vitamin D went on to develop MS. So there's something about a low vitamin D level that makes someone more at risk. Many people know that the farther you live away from the equator, the greater the risk is of developing MS. Some believe it's related to, once again, the vitamin D levels. Farther away from equator, less exposure to the sun. In winter months, the lower vitamin D levels are common, and so that's where the risk factor is. But what they've looked at is migration, and they found that those who grew up in an area where there was a low risk of getting MS, and if they moved to an area of high risk before the age of 15, they adopted the same risk of the place they moved to. If they migrated after the age of 15 or 15 or older, they seem to maintain that lower risk of the area they came from. So there's something about early environmental exposure. Once again, it could be related to low vitamin D levels early on. It puts someone more at risk. The other thing they consider is puberty. Prior to puberty, the risk of developing MS is pretty equal between boys and girls, but once puberty hits, we jump up to that 3-to-1 ratio of females to males. So there's something maybe hormonal happening there as far as a risk factor. The other thing they've considered is obesity. There's more patients with pediatric onset disease who are obese. The theory behind that is vitamin D. Once again, it's a fat-soluble vitamin, and it may be sequestered in the adipose tissue and causing consistently low levels of vitamin D. So they're thinking that may be the risk factor. And of course, there's family history, the genetic propensity. Roughly 15 to 20% will have a family history. We have a number of our patients who have a parent or grandparent or aunt or uncle who've had a history of MS. So there's definitely a genetic propensity. And then there's something environmental, whether any of these things I just discussed are the risk factors for our patients. It's hard to know. It could be a combination, could be that perfect storm that makes them at great risk. So what makes pediatric MS so unique? Obviously, it's the same disease, whether you're pediatric age or adult age, it's the same disease. But what's unique about pediatrics? Well, you're dealing with developing brain and spinal cord. MS is a disease of the brain and spinal cord. What does that mean as far as these children? Is it protective? They're still laying down their myelin. Are they more likely to repair after a demyelinating event? Or are they more at risk because their developing brain and spinal cord are more vulnerable? That's not necessarily clear. We're also dealing with an immature immune system. The treatments are often trying to modify the immune system. Do these treatments work better if your immune system is immature? Does it don't work as well? Is it impacting the immune system? That, once again, is not clear at this point. And also patients are focused on different things. Pediatric patients, as opposed to adult patients, they're worried about school performance. How well am I doing at school, academically performing? What about peer relationships? They want to be liked, they want to have friends. They also want to participate in recreation and play. I always say that school and recreation play are the work of children. And most importantly to them is they want to feel normal. They don't want to feel different at all. Anything that makes them feel different can upset them, and obviously having MS makes them feel different. And we're also dealing with the issues of parental decision making. Parents are very much part of a child's care, and the younger they are, the more they are involved. So that really impacts how you approach the care you provide to the patient. So there's four main considerations in pediatrics MS. You need to provide developmentally appropriate support and education. You need to consider parental involvement. You need to consider the various treatment challenges. And you also need to consider transition from pediatric to adult care. And those are the four main things I'm going to talk to you about for the rest of this talk. Let's start with the developmental issues. So children are constantly growing and developing, and that's nothing new to anybody. But approaches to care do change at different developmental stages. You can't treat an 11-year-old the same way as a 16-year-old. You need to consider where they are in their development, and that changes how they will be, you provide education, how you provide support, and how you provide treatment. Care also involves both the child and the family. You cannot treat a pediatric patient without involving the family. They very much come as one. You also need to consider the main dichotomies in development. You've got a young child who's very dependent versus an older teen who's more independent, but even teenagers are still fluctuating. They're on that spectrum between dependence and independence. They do want to be completely independent, but they still rely on their parents or family members for certain aspects. And sometimes they want to be independent on some things, but not necessarily their health care. So they may be switching more to their dependent aspect when they're talking about their health. Of course, younger children are more concrete thinkers versus the adolescents who are more abstract thinkers. So you have to consider that when you're providing education. And younger children are focused more on the present, whereas older teens are more oriented towards the future. However, teenagers as well can still be focused a little more on the present, a little less on the future at certain times. So always consider that. And of course, adolescents have their own issues. They're very concerned over feeling different. As I said, they want to feel normal. They don't want to feel different from their peers. Peer acceptance and peer influence are also very important. How their peers think and feel and how they act and how they dress all influence how teens think, act, feel, and dress. They also have a preoccupation with body image. So what does that mean when you're perhaps suggesting a medication that's going to cause injection site reactions, or you're going to prescribe something like steroids that can cause weight gain or cause acne? And so it can interfere certainly with adherence. They're also very egocentric in their views. They think the world revolves around them. So you have to keep that in mind when you're talking to them. And they're also very idealistic in their goals. And everybody recognizes teenagers as risk takers, feeling omnipotent, that nothing's going to happen to me. So sometimes that can impact on their agreement to be on medications that are going to help them in the longer term. Or also it can be a bit of a crushing blow to be diagnosed with MS when you feel like you're omnipotent and nothing's going to happen to you. I always like this pictorial of the adolescent brain. Obviously, it's a cartoon, is meant as to be humorous, but the point is that adolescents, what they're focusing on in life, what is important to them, is very different from the adult, and you need to consider all these different aspects when you're dealing with an adolescent. So how does one educate and support children and adolescents? Well, it's important to provide the necessary and the requested information. So you have to really think of what do they really need to know now versus gradually over time, and then find out what they request. And many of them don't ask a lot of questions. Particularly the younger they are, the less likely they're going to ask questions. So it's you need to sort of gauge on where they're at a particular stage. But no matter what the age, I tend to talk about what potential relapse symptoms to report. So obviously you're more sophisticated when you're talking to an adolescent. Younger children, you may focus on the symptoms that led to their diagnosis, to tell their parents if they have any of those symptoms again. And then some of the other things to sort of point out to them in very simplistic terms. So for things like I mentioned about younger children don't always express that they're having sensory symptoms. So talking about just having a funny feeling in their hands or their arm or their leg, anything that feels different, to let their parents know, and then we can work with them on that. With adolescents, I often talk about some of the common associated symptoms, such as fatigue. Many of our adolescents will report that they actually had fatigue prior to their symptom onset and their ultimate diagnosis of MS, so they're a bit surprised that this was actually related to MS. We have many patients who are athletes, so we talk about heat sensitivity, recognizing that they may experience some UTOFs phenomenon if they're overheated and what they can do about that, and just some anticipatory guidance regarding that. Also talk to them a little bit about cognitive aspects. I will talk to you a little more about that shortly, but I'd like to tell them that sometimes teenagers report that they might have some memory or concentration issues, and or they may find they're struggling a little bit more in school than usual, and to certainly let us know and we would help address that. And last but not least, I would talk about mental health issues. So sometimes just presenting it that it's common for people after a diagnosis of MS to feel a bit sad or to feel a bit worried about the future or having another relapse, and but to let us know if there's any sort of overwhelming feelings of sadness or worry, to bring that to our attention to help them. Older teens might talk a little bit about health promotion strategies. Not all of them are interested in that, but some do like to have a little bit of control over their situation. So we'll talk about the importance of exercise, obviously well-balanced diet, getting enough rest, taking vitamin D, and avoiding things like smoking and exposure to secondhand smoke. Really young children worry they're going to die. Because they're maybe being hospitalized, they've had a number of tests, and they see the worry on their parents' face, so they think that, oh, I must be dying. So they need to be reassured of that they're not going to die from this, at least not immediately. Also, with all ages, we talk about treatment options. More sophisticated with the teenagers, younger kids. Even I met recently with an 8-year-old with her dad, and we went through the different treatment options. Said it very simplistically with her, a little more sophisticated with the father, but she was able to ask her own questions about things. So it's certainly important to involve them from day one, no matter what age. And also recognize, as I said, that many do not want a lot of information, so you really need to gear on what they're ready for. And you may need to refer them for counseling if needed, both for support and for even further education. And as I mentioned earlier, you cannot treat a pediatric patient without involving the parents and the caregivers. And we often find that parents are most burdened by the initial diagnosis, more so than the kids. They're more worried about their child's future. What does that mean as far as that perfect child they thought was going to do this, and now this may impact that. They may feel some guilt that maybe there's something they had done that caused their child to have MS. So they're often most burdened about that. So I really find that facilitating adaptation of the parents will help facilitate adaptation of the child. So if you have a parent who feels well educated, well adjusted from all of this, then that will certainly help the child adapt as well. And you really need to educate the parents as their child's advocates and decision makers. And as well, parents who are educated about MS can really support their child. I mentioned a lot of kids don't ask a lot of questions. They may be in for a clinic visit. You ask if they have any questions, they say no, but on the way home in the car, they may ask their parents something. So making sure that the parents feel well educated so they can support the education of their child as well. I also like to mention the potential school performance issues. They may have a child that has regularly an A+ average, and all of a sudden it's dropping down to a B average, and so that we have ways to recognize some of those things, support them, etc. And I always mention about disclosing the diagnosis to others. Quite a while back, a colleague and I did a study on the experiences of children and adolescents living with MS, and we found that a lot of them were upset that they felt like everybody knew they had MS. They were not happy about that. So it's important to talk to parents about and working with the children and especially adolescents, but who really needs to know? Maybe it's a teacher really needs to know, so there can be special accommodations if needed, or it could be a coach if they're involved in certain sports, that if they do have that heat sensitivity, what can be done to adapt that. So, but maybe you don't need to tell the neighbor. So working with the parent and the teen on figuring out who really needs to know. And they may need to be referred for counseling as well. So as I mentioned, there can be several cognitive issues with young people with MS, and actually about 1/3 can have cognitive deficits. The longer they've had the disease, the more likely they will have deficits. So somebody who was diagnosed at the age of 11, they are more likely to have cognitive deficits at age 16 or 17 versus somebody who is perhaps diagnosed at age 15 and then reassessed at 16. Children with pediatric onset MS have been found to have a smaller head size, brain volume, and thalamic volume, so that could be impacting their cognition. And not just those physiological aspects, but there could be other aspects that could be affecting their academic achievement, such as mental health issues. If they're depressed, if they're anxious, that can impact their learning. If they're fatigued, they may not be able to stay awake in school. They may get home from school and just want to sleep and can't get their assignments done. All of those can affect, as well as missing school for relapses, for doctor's appointments, etc. So we always recommend neuropsychological testing and appropriate academic accommodations for all our patients, and that may need to be reassessed periodically over time. What about the treatment challenges? Many of you know, or most of you know, that most disease-modifying therapies are not prospectively studied for safety and efficacy in children. There's many anecdotal reports and some retrospective studies. There's only one study that has looked at prospectively in a clinical trial, and it was with fingolimod. So that is the only one that's looked at safety and efficacy in children prospectively, though all of the disease-modifying therapies are widely used in the pediatric populations. There's still much to learn from that. And also in pediatrics, dosing of medication is typically based on weight. We always want to know how much a child weighs because we prescribed medications, so many milligrams per kilogram per day, where none of the disease-modifying therapies to be tested in that way. They are just based on one dose. So what do we do if a child is 35 or 40 kilos, and most people that are part of clinical trials weigh well over 50 kilos? Do you adjust the dose? Do you give them the higher dose? Is it safe? Is it more effective? We don't always know. And of course, parents are involved in the decision making. So sometimes parents may make a decision that the child may not agree with, and that may cause some treatment challenges. And of course, there's adolescent adherence issues. In fact, 37% of adolescents with MS are non-adherent to disease-modifying treatment. And as this teenage mouse says, I can totally get away with this. You think of developmentally, they're risk takers. They think it doesn't really matter. This, if I just don't think about this, I'll be okay. So they're willing to take that risk and are not always adherent. So what are the adherence issues? Well, actually it's infrequent in younger children because they tend to comply with their parents. But adolescents may question the need for treatment or even reject parental views. Anything their parents think, they might want to do the opposite. And as I talked to you about earlier, developmentally, adolescents don't want to be different from their peers. They're concerned about their physical appearance, and they're risk takers. All those can impact adherence. And there may be other psychosocial issues. There could be, as I mentioned, depression and anxiety. There could be discordance within the family. There may be lack of support from the family. So there's many things that can interfere with adherence in the adolescents in particular. So how can you promote adherence in adolescents? Of course, you need to involve them in the treatment decision making. That is really key. If they're part of that decision making, they're much more likely to adhere to the treatment. And then emphasize how treatment offers them control over their health. That may not be important for younger children, even younger adolescents, and sometimes not even older adolescents, but some do like to have a bit of control, and so offering, talking about how treatment can offer some control over their overall health. And educate in a way that is meaning for them. So what's really important to them in life, and what would the impact of this treatment have on their ability to actually attend school, to participate in their sports. If they have a relapse, that may mean that they're going to miss school, may mean they're going to miss a particular sporting event. So, and you may need to re-educate periodically, depending on where they're at a particular age. You need to explore, of course, issues that make adherence difficult. What is sort of the deep down reasons for adherence issues, and try to explore some of those. And I talked about dependence versus independence and that being on that spectrum. So it's really important to facilitate negotiation around shared responsibility between the parent and child. So they may not be ready to be totally independent regarding their treatment. So how can they work with their parents so that the parents provide the support that they want and need, but not providing too much support, and also allowing a bit of independence for the child, working around a little bit of that negotiation. And of course, address mental health issues. If they're depressed, if they're anxious, that really needs to be treated because that can impact their ability to adhere to treatment. Lastly, it's important to foster an open, caring, and supportive relationship between the teen and the healthcare team. The more they are feel supported, the more likely they are going to be participating in adhering to the treatment regimen. And lastly, I'll talk about transition to adult care. This is a key thing that needs to happen when you're dealing in pediatrics, because these patients do grow up. They move from a pediatric setting to a healthcare setting. And healthcare transition is described as an uninterrupted, coordinated, developmentally appropriate, psychologically sound, and comprehensive process that assists the transition of young people from child to adult-centered care. So why is transition important? Well, more patients with MS are being diagnosed in childhood. They are being cared for in pediatric settings by pediatric care providers, and then they will eventually need to be cared by adult care providers. There have been several studies looking at youth who have chronic illnesses, and that's from diabetes to organ transplant to congenital heart disease, and they found they had increased morbidity and mortality after transfer from pediatric adult health care. involve lack of follow-up. These kids might have appointments and they just don't show up, or if it tries to be rebooked, they don't rebook. They may be non-adherent to their treatment regimen. We often call that lost in transition. But they also found that better health outcomes are observed for adolescents with chronic conditions who receive effective transitioning. So how do you do that? You need to be aware of the education needs of young people who are transitioning. They need to learn the role of an adult with a chronic condition. They know what it's like to be a pediatric patient with chronic condition, but what do they need to know to be an adult with a chronic condition? What responsibilities do they need to learn? They also need to learn how to adopt a health-promoting lifestyle. They're being adolescents who are risk takers. They're not necessarily worried about health promotion. And they need to gradually learn that as I'm older, I realize that how I treat my body is going to affect my MS as well. They also need to learn how to use a new healthcare service. They're very familiar with the pediatric care providers, pediatric facility, how things are done. And then they're also moving to a new healthcare service that does things very, very differently. And also having experience with peers. Young people don't often want to connect with somebody else who with the same diagnosis, particularly children or younger teens. But as they get to be older teens, they really need to learn how to connect with each other, to learn from each other, to share their experiences, and to learn how to cope in that way. So if you're looking after pediatric patients, how do you promote their independence? Well, one thing to do is to offer some solo visits. So initially it may be with both parent and teen, but offering even 5 or 10 minutes with just the teen and the healthcare provider so that the teen can learn how to interact with their healthcare provider by themselves, but also ask questions of their care provider they may not feel comfortable with talking about in front of their parents. Also, I mentioned before about involving the adolescent in decision-making is really key. And ask the child and teen questions directly. And that can start at a very young age. Sometimes initially you may ask them a question, they may turn to their parents for guidance, but over time getting them comfortable with answering questions themselves. And also encourage direct communication with a healthcare team. I often give an example of one of our patients who was diagnosed with MS at about age 8. And initially it was the mother that called if there were any issues or concerns. But I recall when he was in his adolescent years, he had a relapse. The mother called and I was asking about the symptoms, and she would sort of go aside and say, just a second, I'll ask another question, just a second, I'll ask him. And then eventually I said, well, how about let's get him on the phone and I'll ask him some questions and we'll get directly from him. And then after that, he was the one who actually called if he did have any questions and concerns. So he just needed that opportunity to learn how to interact directly. And obviously he felt comfortable speaking with me as well. The other thing too is more and more everybody has electronic charts and may have access to patient portals. So parents may be the ones that have accessed the patient portal, but maybe promoting the adolescent to start looking on their chart and learning a little bit more about their own health. And also share information with the teens and parents equally to help them promote an understanding of MS and the treatments. And as this cartoon says, you can't begin to imagine how embarrassing it is to be seen with you. It's not quite clear who's more embarrassed, but the important thing is that sometimes separate meetings is very important. They've also done studies looking at youth and parental concerns as far as transitions concerned. So if you were an adult care provider that was taking on a patient who had pediatric onset disease, you need to know that they are concerned about moving from that familiar world of pediatric healthcare to the unknown world of adult healthcare. Things are very different. They run very differently. They're also having to establish trust with a new care provider. They may have worked with their pediatric care provider for many years, and all of a sudden they need to get used to this new person. How am I going to build that rapport with them? Will I feel comfortable with that person? Will they listen to me the same way as my pediatric care provider has done? Parents may feel less included. I talk about in pediatrics, we very much involve the parents, but all of a sudden the young adult is starting to see their adult care provider by themselves and they feel less included. Also, they may have concerns that their care providers, having care providers who are less supportive and accessible. That may or may not be true, but we do get feedback from our adult MS colleagues that us pediatric people tend to spoil our patients, and we tend to coddle them a little bit, and so they need to get used to just a different approach and how adult care providers treat their patients versus the pediatric patients. It can be very different. And also they can worry about changes in financial support. They may lose some of the insurance that their parents have. And although our pediatric patients may feel like they're being greeted by aliens, it's really important as an adult care provider to make the young people feel welcome, to help them understand that you understand what they're going through, that this transition may be very difficult. This is how things are done differently. This is how we want to support you. This is how, if you have any concerns, this is how you contact us. They want to know this new system, and they need a bit of time to get used to their new care providers. And I wanted to point out these great transition resources. Got Transitions is an excellent website. They have resources for pediatric and adult healthcare clinicians, as well as the youth and young adults and parents and caregivers. And interestingly, not only do they have guidance for the pediatric and adult care conditions, but they also have information for those people that mostly provide care to adult patients, but do follow some pediatric patients, and helping them. So maybe you're looking after a patient at the age of 15, and all of a sudden they're 18, 19, 20, and they're no longer your pediatric patient, they're now their adult patient. And how do you help those pediatric patients adjust to being that adult patient of yours? And also point out too that the American Academy of Neurology, along with the Child Neurology Society, created a consensus statement on the neurologist's role in supporting transition to adult care. So that is published in Neurology in 2016. So I got 4 main take-home messages. Developmental ages and stages must be considered when providing education and support. Parental involvement is a key component to care when you're dealing with pediatric patients. MS treatment management in children creates unique challenges, including dosing and adherence, but I hope I gave you a few strategies to help with that. And lastly, successful transition to adult care is important and involves coordinated, developmentally appropriate, psychologically sound, and a comprehensive process. And I wanted to point out, because of time constraints, I wasn't able to talk about diagnosing the pediatric patient, which creates its own unique challenges, and the specifics on treatment. But this is an excellent source book for MS care professionals on pediatric MS, and Dr. Ye and Greaves cover wonderfully on how to diagnose the pediatric patient, some of the unique issues, and how to go about treating these patients. So I thank you for your interest, and I'm happy to answer any questions.
Thank you very much, Jennifer. And I'd like to introduce the next speaker, Mary Jean Busey from South Shore Neurological Associates, and she is going to discuss aging and MS.
Hi, I'm Mary Jean Busey. I am a clinical professor at Stony Brook University and a nurse practitioner at South Shore Neurologic, and both of them are located on Long Island. Today I'm going to talk about one of my favorite subjects, which is clinical implications of aging in an MS population. And it's such an interesting topic, and it has become a fascination for many people, and I hope that I could share that with you. So why do we look at MS in the aging population? As we all know, MS is diagnosed between the ages of 20 to 40. Most of our disease-modifying therapies are geared to younger ages or more of a relapsing thing that occurs at younger ages. However, what's happening with our older patients with MS? Well, I think it's just been probably the last 10 or 15 years that we're realizing, most likely because of the DMTs and because of better healthcare systems, that people with MS are living longer. So in 2012, I found this to be a very interesting number. I couldn't find a more recent number, but the peak prevalence of MS was in 2012, 45 to 49 years of age. Now, when you think about MS, when I think about MS, I think the peak prevalence is when people are early in the disease, maybe, 20, 30, 40. But no, in 2012, it was 45 to 49 years of age. And now it's, if you add 8 to that, you realize that it's more like 53 to 57 years of age. So people, a lot of people, most people are getting older with MS. So over time, as you know, the disease changes. It becomes less inflammatory and it changes to neurodegenerative. And with that neurodegeneration, what occurs is more disability for the patient. There's a reduction of relapses and MRI inflammatory diseases. And although I talk about that, yesterday I saw a 58-year-old with a new lesion. So there are outliers. I've had 68-year-olds and 70-year-olds with lesions, new lesions. There are outliers on it, but generally it's much more of a neurodegenerative disease. And there's disability worsening over time. And these are the reasons why we're so interested in those aging with MS, because I think the earliest article I read was 2005 on what does that mean? And so we're learning over time. We're still describing what MS looks like in an aging population. So in the normal lifestyle, in normal aging is not homogeneous. We age differently. I age differently than my friends. And even from my family members, we're all different. The organs in the same person may age at different rates. Sometimes because of environment or lifestyle factors, you may have a heart that's older than perhaps somebody's lungs, or lungs that are older because of smoking. And if you think about the skin as an organ, when we know that when people smoke for a long period of time, their skin ages much more rapidly than somebody who never smoked. So generally in the normal lifestyle, there's a slowing down of systems, and it's influenced by genetics, environment, and of course, lifestyle factors. Genetics play a huge role because, as we know, as people age, if their parents had cardiac disease or breast cancer, it's more of a likelihood for that person to get that. The environment, city versus not even suburban, but the wide open spaces, very different environments and very different perhaps aging, and lifestyle factors really matter, including smoking, obesity, food we eat, etc. So age-associated physiological changes. So as people age, there is a circadian pattern of temperature, cortisol, and sleep, and it's internal. However, it gets changed around. So if a lot of patients who are aging will say, I don't sleep so well anymore. I get up every night. I have to switch positions. I go from a bed to a chair. And I'm cold all the time. And so things change, and there's a circadian misalignment. And this is very normal. This is not people with chronic diseases. This is everybody. And there's something called homeostasis, and you can see what happens. There's diminishing physiologic reserves that are available. And these are challenges. Homeostasis means that we're stable. There are challenges to homeostasis. Homeostasis is stability. Homeostasis is not stability. And there are challenges. And I look at this and I see people with stress and injury when they're young, they can get over it. They bounce back, things are better. But over time, these physiological reserves that we have in our system are not available anymore because they're already in use, from hypertension, high cholesterol, perhaps some cancer, all the things that come along with aging. And then one more stressor, and the outcome can be death or hospitalization. So we're really cautious as patients get older. So these physiological changes include the heart, increased risk for high blood pressure and other diseases. It is quite incredible when I hear of a person in their 70s who doesn't have some kind of high blood pressure. It's it's quite amazing. I think most people will end up with some high blood pressure because over time, our arteries get less pliable and they get stiffer. And so most people will end up with high blood pressure and other diseases in the lungs, really dependent upon exercise and smoking, how well the lungs change. Gastrointestinal constipation is common in older adults. The lack of eating proper foods is more common in older adults, and the lack of drinking water, it will affect them too. And kidneys and bladder, more urinary tract infections, and especially for men, there's prostate cancer. If you're 60 years old and you're a man, you have a 60% chance of getting, benign prostatic hypertrophy, which is an enlarged prostate, not cancer. But if you're 60 years old, you have a 60% chance of getting this BPH. And if you are, as you age, 70% chance, 80% chance. So it's just a gland that grows and grows older as men get older, and something has to be done about that. So because of that, normal men will experience urinary tract infections, frequency, urgency, and hesitancy. And the musculoskeletal mass decreases, the bone loss increases if there's no exercise. And these are some of these things we can work on with lifestyle changes. So the most important thing for me that I'm going to talk about today is the immune system in normal aging. And there are changes in the immune system and changes in immune functions that occur. And these changes over time, as the person ages, lead to increased frequency of infections, malignancies, and autoimmune diseases. So we know, I always say to my patients, and one of them said to me, I think it was yesterday, you know, I'm older and most people I know have something, and I have this and they have something else. But when I was younger, I was the only one with a chronic disease. And that's true. As people get older, their friends are getting older also, and they are getting more malignancies, infections, and autoimmune diseases. And so immunosenescence is the decreased ability of T and B lymphocytes to generate immune responses. And this immunosenescence begins to occur around the age of 50. So when people talk about immunosenescence, they're talking about 50, which I consider quite young. So it's a really interesting thing that our immune system is aging by the age of 50. So these are some of the age-related changes to the immune system, and I hope that you can see this. I found this in Nursing Times from a 2017 article, and I just thought it was fascinating. So you can see that mucous membranes become less resilient, mucus production is compromised, skin is thinner and drier and more prone to injury. And when all that occurs, viruses and infections can come in. Now, when they do come in, you have the innate immune system and you have the adaptive immune response. Both of them are affected by aging. There are less macrophages, decreased phagocytosis. And if you remember what phagocytosis is, it means when you have an infection, all the white blood cells come and they try to eat up the infection so that you don't have to worry about it anymore. They kill, so the killing and the wound healing abilities are less. And in the adaptive immune response, the T cells and the B cells have decreased production and the quality of the antibody response is less. And that becomes very important in people with MS because when we're giving vaccines to persons who are older with MS or persons who are older, it doesn't matter who they are, we know that they do not mount the antibody response that we need. So as we're in the middle of a pandemic and we're all hoping for a vaccine that's suitable, not only must they look at younger people mounting a response, they also must look at older people and see if they mount the appropriate response. So the immune system ages as the person ages. Immunosenescence is universal. It's age associated. It happens to everybody, even though we don't think it may. It's a state of chronic inflammation. And as I talked about, so it's a state of chronic inflammation. So now we have our MS patients who are just kind of gotten over this state of chronic inflammation. And now they're into more degeneration. in their immune system, and now we have a state of chronic inflammation again. And unfortunately, what this chronic inflammation does is it does not it exhausts the immune system, is what I'm trying to say. It exhausts this chronic antigenic stimulation. There's always inflammatory processes going on. It's like having a persistent viral infection. It's always there. And so the immune system becomes exhausted. And on top of that, and you'll see in my next slide, there's thymic involution, which means the thymus is becoming more fatty tissue and less gland that's necessary. Again, there's reduced numbers and percentages of CD8 naive T cells, and immune systems with autoimmune disease accelerate aging. And what age will we start to see that at? Well, it's so interesting because in MS, some people say, immunosenescence is real, immunosenescence is not real. It's real in aging, and we are all aging, no matter if we like it or not. So here is a picture of the thymus, and I wanted you to see this, and the picture on the right is age in years, and you see adipose, cortex, and medulla, and the medulla is where all the thymus was, then the cortex is on the outer side, and the adipose was very small. That's the adipose tissue. As you age and you're 80 years old, look how big the adipose tissue is. It's just fatty tissue. The medulla and the cortex are very small. So that's what happens normally in our patients, in anybody who's aging. And so then you add a chronic disease of MS, it can become problematic. So I always like to say, do a thorough history of the immune system. And when are you going to do that? How are you going to add that into your day? Well, it's just generally how the patient is are there any infections? And I know that in my history of present illness and when I'm working with a patient, I'll ask, any new infections? Is there any weight loss? Is there anything new? Any new diseases that you've had? So anything that might suggest malnutrition, malignancy, or chronic inflammation is telling you about the immune system. Very often our patients with MS, and I find this quite astounding, that as they age, not only do they have MS as an autoimmune disease, but all of a sudden they've got something else, like psoriasis, like rheumatoid arthritis, like something else. They're all of a sudden getting a second autoimmune disease, and that's problematic for our patients also. So you want to review, essentially in the thorough history, you want to review any chronic medical problems and the detailed medication history. I recently had a rheumatologist call me and say, I know the patient's on Tysabri, can I add leflutamide? And I just said no, and they were shocked. And I said, well, they're both treated, almost treated. Leflutamide is the sister of teriflutamide, and we can't have our patients on both. So it's an interesting thing that they did not know that, and I was thankful that I knew that. So immunosenescence and DMT use, well, what's going to happen? We don't know. Older MS patients have lower lymphocyte counts, and they have an increased risk for DMT-induced lymphopenia. And we did see that with one of our DMTs, although it was rare for PML, the rate of PML, the age of PML was definitely older than 50 in most of the group that ended up having PML. So it's interesting, we're seeing this induced lymphopenia in older patients. The DMT, we wanted to have an effect on the immune system, but now that people are aging, what kind of effect is it having? Is it additive? Is it synergistic? What kind of change is happening? And I think that these are questions that we don't know the answers to right now. But I do know a high level of vigilance is needed in our patients who are older and still on DMTs. And let me tell you now, there are a bunch of them. So I know in my practice, I know in many practices, and I'll show you a study where they showed that. So it may add to or potentiate the deleterious effects that the DMT may have anyway. It may make it worse for an older person. So DMTs in older persons with MS, there's, the clinical trials for pharmacologic therapies. They're done in younger people. They're not done in older people because they have to exclude patients with comorbidities. They have to exclude patients with other things to make it a pure trial. However, some trials did include patients up to the age of 65, but the participants were very few. There's not enough data that we can make based on any of the clinical trials at this point. However, numerous older persons with MS are on therapies, and we need increased surveillance. And when do we discontinue treatment? That's a very hot topic now. When do we discontinue treatment? What age? What does that mean? So the MS lifespan, as I said, has increased and so people are living longer, and they're most likely to have a progressive course. And it's so interesting. The only linear straight line predictor of greater disability is older age. So our patients who are older are more disabled, and they also have a lot more problems with their physiological functions that we talked about. There's common comorbidities and physiological changes. So comorbid illness in the United States, more than 50% of people over 65 have 2 or more comorbid illnesses. 2 or more, it's normal. Patients with MS, persons with MS, are likely to have the same illnesses plus MS. So the most common comorbid illnesses are pain, cardiac disease, depression, hypertension, dyslipidemia, and obesity. And many persons with MS try to balance with MS with the health effects of aging. And sometimes they win, and sometimes they don't do so well. So I wanted to put a circle around, this is a chart from, let's see, 2018 about how many people have comorbidities. And I wanted to put a circle around greater than 65. So these are MS patients. And so hyperlipidemia, hypertension are the highest number of comorbidities. But look at arthritis, 10.69. And if you have a disabled person who has arthritis already, it's also a big problem. Diabetes, 7% of our patients may have, or almost 8% will have diabetes. So, and that's at age 65. So we really have to be aware of the types of comorbid diseases there may be. So what do? We need to send our patients for preventative screenings. I know in my office, I'm not monitoring their blood pressure except when they come in. I'm not monitoring their blood work, unless it pertains to the DMT that they're on. Going to a primary care provider who does this. Lipid disorders, they have to do fasting glucoses. I know I'm not doing EKGs. I hope you aren't either, because that's really not our specialty. Patients will need vision and hearing exams, osteoporosis screening every 2 years in the States. And so all the cancers and all the sexually transmitted disease and smoking and alcohol abuse, all that has to be screened for, and that's what the PCP is for. Depression and dementia, we might be doing some of that screening. Fall risk, at times I'll do some of that screening, but I definitely don't do testicular and prostate cancer, pelvic or breast exams ever. And mammograms should be done bi-yearly depending on risk. Other specialized screenings for persons with MS, pain, depression, and health-related quality of life. And we do know that persons with MS can have all those 3. When we evaluate symptoms of aging versus MS, it's really, I have young people who are in their 40s and say, you know, my memory's not so great, but it's my age. And I say, it's not your age. You're 40. It's not your age. It's probably your MS. But when people are aging, is it their MS or is it something else? Is it dementia? Is it a new symptom, progression, exacerbation, or a different process altogether? So separating symptoms can be very important, yet can be difficult. I do have some patients with MS and Alzheimer's. I do have some patients with MS and Lewy body disease. And those are different types of dementia or vascular dementia. And so I had to tease that out because we know patients with MS who are older have decreased in cognition, increased fatigue, they may have spasticity. What is going on with this? And lastly, if the patient is taking a disease-modifying therapy, what is it, and can it affect any of these issues? So pain, most older adults experience age-related pain, but 70% independent living patients report chronic pain. Pain is common in MS, with headaches, low back pain, neuropathic pain, spasticity. And MS pain continues to exert increasing demands on the person who's aging compared to other disabled populations. So we continue to have pain despite aging. Pain also reduces HRQOL. And depression and anxiety, symptoms of anxiety is about 20% higher proportion in MS than the normal population. And I'm telling you, through this whole pandemic, it's a heck of a lot higher than 20% now. 1 out of 5 persons with MS experiences significant anxiety, and this contributes to decreased HRQOL. Less anxiety in socially active patients. So think about that. Socially active older patients have less anxiety than those who are not socially active. We talked about the cognitive changes. As we know, cognitive dysfunction is up to 50% in persons with MS, and older patients especially can be susceptible. Is it aging? Is it dementia? Is it MS? We have to tease that out. So health-related quality of life is an important construct. And this is the person looking at themselves, and you ask them questions. There are many surveys, many questionnaires that ask about their physical functioning. Are they able to complete their activities of daily living? How do they feel about themselves? How do they feel about their sense of well-being, satisfaction with life, psychological status, and social functioning? How is that going? How do people with MS feel about that? Well, I found this article, which I just thought was so interesting. And this is from Michelle Plowman's group. I think she's in St. John's, Canada, or Newfoundland, somewhere in that region. She looked at factors of healthy aging, and this is from 2016, but it was just a fascinating article. She looked at 683 older patients. She divided them into 3 groups. Her team divided them into 3 groups, 55 to 64, 65 to 74, and greater than 75. The mean age was 64. The time with MS was about 33 to 40 years. And these were her findings. She did a qualitative study, which she looked at what are people saying? What is it to them? What is the factors that they need for healthy aging with MS? The first thing was social connections. And I'm sure you could see why that would be so important. Second was attitude and outlook on life. These things keep people healthy. And within that attitude and outlook on life, in the older than 75 age group, it was just so important to them to keep their self-identity. They had to keep their self-identity as they aged with MS. Lifestyle choices and habits were very important also. And one of the reasons for that is that they knew if they made good choices and good habits, they would have a healthier aging. They would have healthier aging. The healthcare system, very important for us healthcare providers. What she found was they valued their healthcare providers, especially those who listened to them, who heard their opinions, who acknowledged their feelings and gave support. Spirituality and religion was important in 6% of the patients, and independence and finances in only 2%. So that wasn't as big of a deal as other things were. And so between all these 3 age groups, there was little difference in what people needed what they believed they needed for healthier aging. So I love this wheel that she developed, and you can look at healthy aging with MS on the left, lifestyle choices and habits, on the right, social connections, on the bottom, attitude and outlook on life. Those were the 3 most important things for people aging with MS. Less important, but still very important, was effective and accessible healthcare, spirituality or religion, independence, and financial flexibility. So this is what our patients need, and this is what they want as they age. So quality of life, fulfillment, accomplishment, feelings of doing well, positive attitudes towards death. They have a desire to form bonds with others, commit to relationships. These are our older people. Integrity is so important, and feeling of union with the past, a sense of a good life. Integrity leads to better QOL. Findings that decrease QOL and increase QOL What increases it? Exercise, social interactions, aging in place, which means aging where you live in your house, and engaging in health promotion. Decreases include pain, decreased cognition, depression, anxiety, fatigue, and sleep disorders. And as healthcare providers, we can hope to move that decrease in QOL over to an increase. So what do? We have to really understand that older adults with long-standing disease seem to adapt to their MS. They have better symptom coping, health promotion, and quality of life. However, they need social interaction, they need to exercise, they need someone to listen to them, and we need to promote their independence. So in summary, so important, the prevalence of aging in persons with MS is increasing worldwide. It presents unique challenges, including a high burden of comorbidities and an altered immune system profile. What do we know about disease-modifying therapies? The safety and efficacy in older patients is still unknown. However, a substantial portion of elderly patients with MS, we have to decide, do they continue or discontinue their disease-modifying therapy? And data are insufficient to provide evidence-based recommendations on this topic, and complementary lifestyle modifications that promote wellness and cognition can help aging patients with MS to manage their comorbidities and improve their quality of life.
Yeah, hi, this is June Halper. I want to thank you all for attending. Colleen, do you have final words? I think Colleen is having some technical difficulties. So on behalf of the IOMSN, Mary Jean Busey, Megan Weigel, and Jennifer Boyd, thanks so much. Colleen, I'm really sorry you're having technical problems, but we're just gonna have to try this one again in the future. A wonderful program. I hope you all enjoyed it. Don't forget tomorrow's program for MS nurses with Amy Perrin-Ross, Marie Namey, and Denise Bruin and Tricia Pagnata. So it's gonna be a great program. Thanks for coming. Talk to you soon. Bye.